if people are joining. Okay. Okay, let's share the drive. We can go through these flow charts after we are done to make things easy on you. This is my flow chart that I used in my exam anyway. Okay, we'll go from square one. Who's starting, guys? Yeah, can you guys just tell me your name because I can't see you. I cannot see you. So just tell me who's starting. Gagan. Okay, Gagan. Wait a second. Wait a second. Let's do timer. Okay. Okay, Gagan. So nocturnal enuresis. Okay, I'll ask you the question. Maybe I'll ask you a different question. Don't ask yours. I'll ask you the question. Okay, first of all, so what's the importance of this piece of information, 100 mil per hour? Is he? No, no, no. Regardless of the body weight, we don't depend on the body weight really in assessing diuresis. Theoretically, yes, you might depend on that, but clinically, we never depend on that. So 100 mil per hour, do you think he's diuresing? Okay, fine. So that's wrong. How would you determine whether the patient is having acute urine retention versus HPCR versus low LPCR? Okay. Is it anything else other than because you can't do an ultrasound in the A&E department? It's very difficult to do that. How would you determine if it's high pressure or low pressure? Can't you do a kidney assessment? EGFR, for example, or creatinine? Yeah. Yes, of course. Okay. Right. So what's next? How would you assess this patient? So say that again. Say that again. What would you request investigation-wise? So tell me about the PSA in this scenario. What do you expect the PSA will be? Okay. So what do you mean stuffs? What did that mean? So let's say, give me a second. Let's say his PSA is 300. What's your next step? What do you mean? Wait a second, Gagan. What do you mean MRI? MRI on what? Why? Why like you will do it like during this acute episode or later on? Okay, so that's correct, but this is not the correct answer for my question. So if his PSA is 300 or 400, will that raise any? Okay, that's not the right answer. Okay, continue. Fine. Okay, so you will request blood test for this patient, including PSA, and would you request ultrasound? So, hmm, okay, 1 second here. Fine. So what's the importance of knowing that he has, so he has dropped kidney function, fine. And his kidney function after catheterizing him came back to, it shows a trend of going back to normal, okay? Why do you still need to do an ultrasound? What's the point? Even if there is hydronephrosis and you put a catheter in and the creatinine improves, because we assess the creatinine, obviously, not the eGFR, the creatinine start improving, why do you still need to do an ultrasound? So what will that change? Will that change your management if there's any there will be definitely residual hydro. Will that change your management? Mhm. Yeah. Right. Okay, we'll talk about this ultrasound. So why does the patient experience no? So when in your history you missed many stuff obviously, and you missed the red flags. One of the red flags is nocturnal enuresis. Why is it happening, and why is it a red flag? What is the definition of nocturnal enuresis? What is the definition of enuresis? What is enuresis? Well, we all produce urine. Are we all having enuresis? We all go to no. It doesn't know. That's not enuresis. That's not enuresis. Otherwise, we all have enuresis. Fine. Okay. So, okay. So, do you know why it's a red flag? Okay. When do you? So, this patient, examination-wise, has no abnormalities. Blood test is normal. DRE smooth enlarged prostate. Why does this patient? Okay, fine. What do you expect to see in urodynamic trace in this patient? Why did what? Okay. Hmm. So what did that has to do with like leaking urine? What do you mean? How will that be reflected on the urodynamic? So what's the diagnosis? What's the diagnosis of this patient? What does he have? Is it acute urine retention or high pressure or low pressure? Why is that? Why did you say that? Who said that? I said blood test is normal. Very good. That's a good answer. So what do you expect to see in the urodynamic? Okay, it's time. How do you think you did? Yeah, this was your first time. That's fine. You didn't do bad, but you didn't do very good. But you didn't do bad, to be fair. So you started. So actually, I asked you the first question. It wasn't my intention to ask you this first question, but you made a big mistake in this. 10 mil per 10 mil per hour. It's not a definition of diuresis. So what we do, 100 mil per hour is not a dial. So what we do is 200 mil in 2 consecutive hours, 200, 200. That could be an indication of diuresis. It's not diuresis. It could be an indication of diuresis. There is no guideline suggesting that 200 per hour in 2 consecutive hours is diuresis, but based on our clinical practice, we consider that. We have a high suspicion of diuresis when the patient produces 200 mil in 2 consecutive hours. That's number one. So that's a very big mistake you mentioned, and it could be a failing. Then you mentioned the definition of each of these titles very well until you mentioned in the high pressure chronic condition you depend only on the ultrasound. That's incorrect. You depend on the kidney function plus minus ultrasound. The guidelines suggesting that we should do an ultrasound with kidney function. However, it's very debatable in our practice, and we'll talk about it in a second. So that's in regard to the first question. In regard to the second, how would I proceed? I will proceed with taking a detailed history of this patient. You ask about the lower urinary tract symptoms very well, which included obstructive and irritative symptoms in the few last months. And you need to ask about blood in the urine. That's very important, right? And also you need to ask about recurrent water infection. These are all in this square, in the upper square, I would say. Then you need to ask about red flags, nocturnal enuresis, because that could indicate most likely that we are dealing with high pressure retention. Could nocturnal enuresis mean leakage? So could nocturnal leakage happen with low pressure retention? It could, but in a very low percentage, most likely in a high pressure retention. So that's a red flag. Whenever there's incontinence at night, that's a red flag for me. And obviously blood in the urine, you can bring it down here. That's a red flag for me. Loin pain, etc. All these are red flags. Bowel symptoms, very important. Constipation, etc. All that contribute to retention. Comorbidity is very important, and I would also consider precipitating factors, even if it's high pressure retention or low pressure retention. That it could be acute on top of these. So I would always ask about precipitating factor. Anything you did differently. Probably he drank big amount of beers or whatsoever. Any precipitating factor could be really appreciated in the history. Examination wise, you did mention the examination in details. Very good. I can't really remember if you mentioned chaperone or not. General examination. Okay. General examination is really important here. Assessing the blood pressure of the patient is always important with retention, because it's raised in 50% of the cases. 50% with acute retention will have their high blood pressure above normal. 50%. That's really big number. Nothing about chronic retention, acute retention, and the BMI of the patient, etc. All that really important. Assessing any comorbidities in local examination. We examine 5 areas: abdomen, back, genitalia, DRE, and lower limb. It's very important in patient presented with retention to examine his lower limb for any neurological deficits. Even if the DRE is normal, I would assess the lower limb to make sure I'm not missing something here. If the patient has PSA, yes, we do PSA. That's true. The reason why we do PSA, because if it's significantly elevated, that could raise a suspicion of possible malignancy with cord compression causing retention. So you need to mention that to the examiner. Say that again. Okay. So significant, imagine that you have a patient with acute retention with a PSA at 2000, for example. That's definitely most likely we're dealing with malignancy and cord compression. This is the indication of the question, actually. Okay? So be careful. It is true that you will request MRI on the prostate, etc., but we are talking here about the acute scenario, about the emergent situation. What is the implication of significantly elevated PSA? Okay, you need to be very relevant to the case. Okay, what do you expect on the urodynamic findings? You need to go back to the diagnosis. Well, I will tell the examiners, most likely we're dealing with low pressure retention, so it's very likely in the voiding phase, I will see weak detrusal muscle with weak flow. It could be associated with element of obstruction, it could be not, we don't know. But I'm pretty sure that I will find weak detrusal contraction and weak flow, obviously. Or no flow maybe, or weak flow. Is there any obstructive element? We can't really tell until we make the diagnosis, like Abram-Griffith equation. Is that clear? Okay, who's next, guys?
A question, if you don't mind, on that case. Yeah. 2 questions. You said creatinine is a better tool than EGFR.
Yeah.
Is that because of the invoice, the graph, invoice graph?
Yes. You need to know that by heart. We will talk about it in technology.
Okay, and secondly, I saw in the Oxford Handbook that creatinine between, I think, 110 and 135 is only like about a 10% chance of seeing hydronephrosis by blown system, and creatinine over 135 is only about 30%. That I find that's quite interesting. I'm just wondering if that is your comment.
I'm not surprised. Yeah, I read that. Right. I'm not surprised. This is why we don't really depend on the ultrasound.
Okay.
Ultrasound. So if you are asked about, if you are grilled on this, because in our practice we don't do ultrasound. Most of the time we don't. The only I would say in my practice I don't really do an ultrasound unless the creatinine is not improving or the EGFR is not improving. In that case, I would do an ultrasound. If I put a catheter in and the patient is not diuresing, and the EGFR is not dropping, is not improving, sorry, and there is still hydronephrosis, what's your next step? What's your suspicion here?
It'll have to be the ureters being nipped off at the UV junction.
Okay, tell me your
obstruction. There's probably obstruction at the distal ureter, or it's probably official. But it's possible that would be my thoughts. Yeah.
Yeah. Anyone else?
In other words, malignancy. That's
exactly.
That's off the ureter.
That's what
could be a renal cause problem.
Could be what? Say that again.
Renal cause, like we need to involve.
No. We're talking about patient with hydroureteronephrosis. Hydroureteronephrosis post-renal. But there is no improving of the hydro. So that indicates, as Mr. Charles mentioned, there's distal obstruction. But most likely, the first thing comes to my mind is malignancy, prostate cancer. That will nick the ureters. Obviously, it could be not. It could be different. It could be erythroperitoneal fibrosis causing obstruction of both ureters. It could be anything else. But I'm talking about what comes in your head and what's common is common. So I think most likely there is a problem with it. Could be prostate cancer. It could be bladder cancer. Like bladder, it's unlikely because you have an ultrasound anyway. But this is what you need to think of with the examiner. Okay, just think what you do in your practice. Don't overthink. This is what we do in our practice, so don't overthink. Very good. Okay, so who's next?
I can do it. Ahmed.
Okay. Give me a second. Let me add one patient. Okay, Ahmed. Give me a second. Let me put a timer for you. Okay, Ahmed. Okay, so we will continue on the same case. So your colleague diagnosed this patient as low pressure retention, okay?
Yeah.
So I want you to tell me, don't look at the slide. just tell me, what are the options of treatment? So you are discharging this patient from the hospital. I assume that he will have a catheter. He will be discharged catheterized. What's your next step? What are the management options for this gentleman?
For low pressure urine retention, I will organize for him appointment for TWAC, and if managed to pass urine, I think he might pass this trial. But if we do teach him intermittent catheterization, and we will discuss with him surgical option in form either inoculation or TURP according to graft charts.
Okay, fair enough. The patient is not happy with IC or catheter insertion. He wants to proceed with TURP. Hence, since his prostate is around 70 cc. What's your concern here?
Concern is about the trousers underactivity, which may be contributing to this low pressure urine retention, and that's why I would counsel him a chance to improve his symptoms after the procedure is might be not significantly improved after the procedure, and they might still need continue intermittent catheterization or suprapubic catheter.
That's very good. Can you support that with any evidence? Have you heard about Galayini trial, an Egyptian Galayini trial 2005?
No, it's
which shows that there is a high risk of failure to pass urine to TWAC after operating on low pressure retention prostate. Okay. Very good. Can you differentiate between the management of low pressure retention and high pressure retention?
Yeah, high pressure retention is the patient not for TWAC, and they need a catheter until the surgical option, or a long-term catheter if he's not fit for surgery, and but low pressure retention might give him a chance, and might be booked in for the surgery as a routine, not as urgent like high pressure urine retention one. That's for the management. Okay,
fair enough. So can you tell me, if you have two patients, one with low pressure and one with high pressure, when would you offer this TURP, like time-wise, and when would you offer low pressure TURP time-wise?
After making for high pressure urine retention, after making sure kidney function getting back to the nadir, which may be 6 to 12 weeks, I will organize from the surgery. But for low pressure retention might be done more routinely as in comparison to this one, according to the graft charts.
Okay, what about if the high pressure retention kidney function didn't come back to normal? So what's going to happen here with this patient?
So this patient might have. I would check his kidney. I would check his kidney drainage by upper tract scan. I will do simply pelvic abdominal ultrasound to rule out persistent hydronephrosis or no, and according to the scan finding, I will proceed.
Okay, the scan shows no hydronephrosis.
So the patient might be developed CKD. So I will go back to the patient history and rule out any precipitating cause like diabetes or hypertension, and involve a nephrologist for either pre-renal or renal cause.
Would you consider TURP?
If persistent highly elevated kidney function, it's not. It is not suitable for going ahead for surgery at the moment, because might increase the risk of complication. So I will continue catheter.
And I'll so the patient's kidney function did not improve over many weeks. So as you said, he became like he's having chronic kidney disease now.
Yeah.
With a catheter, dropped kidney function, let's say around 30, it was 90. Would you consider TURP?
I think is might not get the benefit from that, and they expose him might expose him for complication from the surgery unnecessary, so might keep him on the catheter long term.
So I don't understand your point. So Like you will keep him struggling with the catheter for the rest of his life. So what's the point? So what's the point of doing TRP for high pressure in the first place?
That's mean to help to improve the drainage of the kidney upper to drain the bladder and so decrease the pressure from the bladder. And
it's not to improve because it's improvement to prevent further deterioration, right?
Yes.
The same thing here. He has a chronic kidney disease, but if you keep him with the catheter, he will struggle. If you take the catheter out, he might deteriorate more. So I would do TRP still for chronic kidney disease patients. Doesn't make any difference.
Okay.
Okay. Very good. You did very well. 67-year-old gentleman admitted to A&E department with acute painful urinary retention. How would you proceed?
I'll go to review this patient urgently myself, assess the patient, making sure he has, and making sure if his catheter is deserted or no. If not, I will give him painkiller and once he release a catheter after a brief history from the past medical surgical history and ruling out previous catheterization or previous urinary retention episode. After catheterization, I will continue examination of the patient by abdominal examination, DRE, and neurological and lower limb examination. Monitor the urine output hourly. The residual volume first, then hourly urine output monitoring. Send urine depth for send urine for depth and check his kidney function and the base A.
Okay, fair. So, okay, fine. How do you think you did?
I don't know about the study for the high pressure retention for low pressure urine retention success rate and the CKD management of high pressure retention or persistent CKD after high pressure retention. This one is good, is a new information for me.
I think you did very well, Ahmed.
Thank you.
No, seriously, you did very well. I can't see you presenting or performing. I'm not really sure if you have good body habitus, you're moving your hand properly. So that's very important in the exam, by the way. That gives confidence and gives a consultant image to the examiner in front of you. But your performance is really like you sound really good, confident. If we go to the questions, the urodynamic findings very accurately said. What's your concern here? You mentioned that very accurately, that he might not empty. So there is a chance that you will end up with a catheter. I like that when you said suprapubic catheter, that's very good because we don't like long-term catheters. I will talk about why is that. Probably you all know that, but we'll talk about it in the technology station. And you talked about the possibility of IC as well. The management between low pressure retention, high pressure retention, very well mentioned. Good job. There's nothing I can add really here except the study. In regard to A&E department, I think also you need to be more organized. Don't rush. Unless you are very, very organized, so you can talk like in a speedy way. But if you're not very well organized, when you talk very fast, you will mess everything. So the examiner won't really remember what you said. So once I go to see an A&E patient, I always start, I will go and see this patient and make sure that his vital is stable, right? Whatever, you need to make sure that his vital is stable. Sometimes you need to mention ABCD. However, this is not trauma. It will be overkilling, but at least I will say I need to make sure that the patient is vitally stable because that's really important. Then I will take a very brief history, asking the same question you ask about if the patient experienced any previous retention before, if the patient is in pain, he has any lower tract symptoms before, if he's on blood thinning medication, all that stuff. And then, or if he has any underlying malignancy or neurological condition. Then I will proceed with examination the same way you did. And it's very important to do DRE examination, and I'll proceed with catheter insertion. We'll see what's the next candidate will say. Very well done. Good job.
Thank you.
Excuse me, Ahmed, sorry to interrupt. I just have a question. Ahmed just mentioned Griffith chart. Does it mean they get it right first time? It is a chart. I heard something about drift chart or something about. I can't remember.
Tell us, Ahmed, about that.
Yeah, it's getting it right first time. I will share it in the group. I have a chart. I will share it on the group.
I mean, do we mention this in every intervention or every? This is my question. Do you? It's like something we can say. It's.
Well, I never mentioned it. I never mentioned it. I never read it actually. To be fair, but if it's something updated recently or something candidates using now, so just mention it. Just read it and go ahead with it.
Can I just interrupt? Sorry, Sushruth here. Mr. Ahmed, in what context you mentioned the GIRF chart? I just wanted to know.
Ahmed, this is for you.
Sorry again. Can you repeat?
Sorry to disturb you, Mr. Ahmed. Yeah. I just wanted to ask you, in what context you mentioned GIRF chart in this patient's assessment?
Yeah, because in this GIRF chart, high pressure hypertension need urgent treatment or urgent surgery, maybe 3 or 6 weeks. 6 to 3 months, 6 weeks to 12 weeks. But for low pressure hypertension can be managed more electively or more routinely, just mentioned in the GIRF chart.
Right, because actually it's from the NICE guidance, which says that if patient has a catheter or in case of high pressure retention, you do the surgery in 4 weeks. I was not sure that it's mentioned in GIRF. I'll recheck again, but thanks.
Okay, I will find it again. I will share it in the group. Give me just a few seconds, mates.
Okay, fair enough. Let's continue, guys. So who's next?
I can try.
I can do the next one. Yeah.
Okay, fine. So let's continue on the same case. So this patient is presented to you with acute urinary retention, and the patient was catheterized. What would be the first thing you do after catheterizing the patient?
So after catheterizing the patient, I would firstly monitor the urine output.
Guys, can you hear me?
Yeah. Can you hear me?
Yeah, guys, can you hear me?
Yes, we can.
Okay, wait a second. Guys, I can't hear you. Can you hear me?
We can hear you.
Yeah,
we can hear you very well.
I can't hear anyone. Let me stop sharing. Let me stop sharing, and I'll just share with no. Guys, can you hear me?
Yeah.
Yes,
I can
yes,
hear you.
we can. Yes, I can.
Okay, fine. So okay, what's this? So the patient was catheterized. What is the first thing you would do after catheterizing the patient?
So after catheterizing the patient, provided that I've taken proper history and the patient, I would monitor the urine output, make sure the patient is not taurising, and also I would start this patient on tamsulosin as per the alpha study, and arrange for him to have to walk in about 1 to 2 weeks time. Ideally, in the alpha study, they offered to walk in days, but this is not happening in real practice. So the patient after catheterization.
Okay, fair enough. Very well said. Okay, so what investigation would you request for this gentleman, Mustafa?
So first of all, I would request a urine. I'll do a urine dipstick and urine MSU, and make sure do a baseline including a full blood count, EGFR, and creatinine, and also if there is any derangement in the EGFR, I would do an upper tract imaging in the form of an ultrasound scan. Also, I would perform a PSA blood test, as part of the routine investigations.
Very good. So what's the role of doing PSA tests in a patient presented with acute retention?
So basically, I understand that the PSA will be elevated given the retention and the recent catheterization. However, I do it just to rule out any significant elevation which may raise the concern of prostate cancer.
Okay, this patient is 67-year-old gentleman. So what's his normal PSA supposed to be?
As per the Osterling form, Osterling age reference would be 4.5, I guess, if I remember. Well,
I wouldn't say I guess, but that's correct. Okay.
Yeah, 4.5.
Fine. Okay, so his PSA is 11 nanogram per deciliter. What does that mean? Is it significantly elevated in acute retention or not?
So, given the history of retention and risk cancellation, this is not considered significantly elevated, and I will consider repeating this about 4 to 6 weeks time, provided that the DRE is normal.
Okay, I like that. Very good. However, your colleague requested MRI scan. It's negative. Both are correct. Good job. Okay, so this patient, you started this patient on tamsulosin medication. Is that correct? And you mentioned Alfor trial. And because of logistic point of view, we TWAC them in 2 weeks, not 2 days or 3 days. So the patient successfully TWAC'd. What's your next step?
So next step, I would advise the patient to continue on tamsulosin, and I would like to see the patient in about 6 weeks' time, arrange a follow-up appointment as per the NICE recommendation, when I would take history again. Before the appointment, I'll provide the patient with the IPSS questionnaire to fill before coming to the clinic.
Just slow down. Just what's the name of the questionnaire?
IPSS questionnaire.
Very good. Okay. So tell me about the IPSS score.
So the IPSS questionnaire is the International Prostate Symptomatic Score. It's a tool to assess the patient patient LUTS, and it has 7 questions, 4 about voiding LUTS, and 3 questions about storage LUTS, and 1 question about quality of life.
So tell me about these symptoms and signs. Enumerate them for me.
So the voiding symptoms would be intermittency, hesitancy, weak stream, and the storage LUTS would be frequency, nocturia, and urgency. And the quality of life score, it has a score from 0 to 6, with 0 being happy and 6 being unpleasant or unhappy. Oh, sorry, 5, okay. From 0 to 5, not to 6.
Okay, fine. That's very good. Okay, so the patient is in tamsulosin. He's not really very much improving. You requested a flow rate for him. What are the axes? Tell me, what did the y-axis and x-axis represent in the flow rate?
The y-axis represents the longitudinal axis. The p represents the Qmax, while the transverse axis represents the time of voiding time. And in the flow rate, we need to comment on the voided volume. Make sure the patient is voided the required 150 mils for the test. Comment on the Qmax. Comment on the post-void residual volume, and comment on the shape of the curve as well.
That's very good, Mustafa, mashallah. Very nice. Okay, good. So in regard to this gentleman, his Qmax is 7.5 milliliter per second. He voided 189, so this is accurate. And his post-voiding residual is 79. So what's your next step here? What does that represent, Qmax 7.5?
So Qmax 7.5, as per the Reynolds study, it represents gives a chance of 90% of obstruction, as it's less than 10%. So there is an element of bladder outlet obstruction here.
That's beautiful. Tell me about the Reynolds trial. When was it done, and what's the number of population?
I can't recall really when, but I understand the number of patients were around 2,000 patients, and it concluded that when Qmax is less than 10, there is around 90% chance of obstruction. If the Qmax is between 10 to 12, the chance of obstruction is 60%. However, if it's more than 15 milli per second, it's around 25 to 30%.
Very nice, Mustafa. Okay, the Qmax is 7.5 mil. What's your next step?
So this patient is still having, still symptomatic with low Qmax, suggesting obstruction. So sorry, what's the patient age? 67, isn't it? Okay.
67.
Yeah, and the patient is not improving on monotherapy, so I would counsel the patient for combined therapy in the form of tamsulosin and finasteride, and this comes from the data from the MTOPS trial, which showed that combined treatment will improve the patient's symptoms and prevent symptoms progression.
Very good. I like that. So what do we mean by prevent symptoms progression? What symptoms we're talking about?
So as per the MTOPS trial, symptom progression will include a drop in EGFR, any increase in IPSS score by 4 points, if the patient develops recurrent UTI, and also if the patient develops urinary retention.
Incontinence.
Yeah.
Okay, fine.
Yeah.
Very good. Well done. Okay, so the patient is not really happy. So you're gonna give him finasteride medication and combined with tamsulosin, right? So wouldn't you tell him anything about the finasteride medication?
Yeah, I would probably counsel him for the finasteride. First of all, I'd need to make sure to explain to the patient that the medication takes around 6 months to show a full effect. Also, I'll counsel him about the possible side effects, including mainly the sexual side effects, including erectile dysfunction, gynecomastia, and also loss of libido.
Okay, what is the percentage of erectile dysfunction in finasteride medication?
It's around 5%.
What about loss of libido?
I believe it's 3 to 5% as well.
Okay, fine. So we're done. How do you think you did?
Yeah, I think it went quite smoothly. It went quite well. Yeah.
I think you did very well. Very fluent, very confident, very good speed, very good knowledge. You're not hesitant. So you did very well. Well done. If we go back to the questions, so the only thing I would add is when we assess acute painful retention, again, you didn't start. Yeah, you didn't start from the beginning of the case.
Yeah.
So the PSA is elevated. Once it's elevated, you can repeat it, obviously. If it's less than 20, as per the EAO guidelines, you can repeat it after the retention is resolved. What you do in your practice, this is what you will need to mention. What we do in Leicester, for example, if it's above 10, we straight away go for MRI scan just to confirm we're not missing anything, because we know those patients will fall out of the radar. Yeah. But it's fine. What you mentioned is completely correct. It's not incorrect. Always remember, any patient presented with acute retention, it's always important to examine the lower limb, neurological examination. Just make it routine. It's never wrong. That's number one. Number two, you did mention the DRE examination, obviously, right?
Yeah, I did.
Yeah. Number two is whenever you are seeing a patient with acute urinary retention, always try to figure out what's the cause of the retention. Is it precipitated retention? Like for example, the patient went and drank like big hunch of beers. That could precipitate retention in 3% of the cases in a normal people. Or it's spontaneous retention. Patient had LUTS, lower tract symptom, he just developed retention because the prognosis is different. The chance of successful TWAC with precipitated retention is way higher than spontaneous retention. So that's an interesting thing to mention to the examiner. That will boost your mark. So we went to the QMAX. Very good. Well done. You mentioned everything without being asked. That's very good. You know about the X and Y axes, so you know what you're talking about. That's very good. Always remember, guys, after the flow rate, I did mention this in the big, in part A lecture. After flow rate, you expect three things: either to start tamsulosin, if the flow rate is adequately emptying more than 150, you start on tamsulosin or finasteride whatsoever. Or if the patient is young with sexual transmitted disease, so we're talking about stricture, that's the second scenario. Or if the patient emptied less than 150, so we're talking about urodynamic. These are the only three scenarios you can face in the exam. So that's really important. Okay, so always remember, Mustafa, whenever you, give me a second, please. Whenever you mention any medication, you have to mention the dose, you have to mention the indications, which is fine because you don't need to mention indication in this case because we know what's the indication, but you need to mention the dose, you need to mention the complications, and you need to mention the contraindications. before. You don't need to be prompted for that. Once you mention a medication, that you need to mention all that. Yes, Mr. Muhannad, Muthanna. Yeah, we'll talk about it. Don't worry. We have this scenario. Okay, we have this. Okay. Who's next? Hello.
Yeah,
I can do it.
All right, that's fine.
Okay, can you say your name, please?
Alomari Mohammed.
Okay, Muhammad. Fine. So before we continue on the same case, let me just challenge you on something. Let's say this patient is not tolerating tamsulosin from the start. You started him on tamsulosin, he's not tolerating it. He developed dizziness significantly. By the way, what's the chance, what is the percentage of having dizziness with tamsulosin?
Having dizziness with tamsulosin, it's up to 20%.
Is it? Okay.
I'm not pretty sure, to be honest. I don't know.
Fine, that's too high. Okay, what about, okay, fine. So the patient's developing dizziness or bowel intolerance or whatsoever. So how would you manage this case? If it's from the start, he can't tolerate tamsulosin, what would be your next step?
Sorry, because I was on call, so I was receiving calls. So I'm not pretty sure what was the case before that.
So this is a patient, okay, so this is a patient presented with acute urinary retention and he was twacked. You brought him back to the clinic to do a flow rate. He has a poor flow. And he's symptomatic because poor flow by itself is not an indication of treatment. Poor flow with symptoms is an indication for treatment, right?
Yeah.
So you started him on tamsulosin medication, but he's not responding to it's not about responding. He's not tolerating it. He's having diarrhea or whatsoever. What's your next step?
So depending on what he's having, if he's having dizziness, we can advise him to take it before going to sleep. If he can't tolerate it for something else, or he can't tolerate the dizziness in general, we can check what's the patient prostate size and what's the PSA for him. So we can start him on finasteride at that time, and we can talk to him regarding the possibility of doing self-catheterization if there was a high post-void residual during after stopping the tamsulosin. This is one of the options. The second option is to talk about the possibility of watchful waiting if he is doing well, like with no symptoms. The other option will be to do surgery for him. But we need to repeat the flow rate and everything after stopping the tamsulosin for him.
I like that. Very well. Good job. Okay. So let's continue. So what is the downside of tamsulosin medication? What is the complication?
Complications. So first of all is dizziness and retrograde ejaculation, which occur like in 9% of patients. And also there is a possibility of nasal congestion and the orthostatic hypotension, and the allergic can occur also in a very minor patients.
And athenia, that's 15%. Probably you were referring to this 15% general tiredness. Okay, very good. So what is the study support tamsulosin medication as a first medication?
Sorry. So I believe it was the combat study that showed that it caused decrease in the, there is also the Conroe study that showed that tamsulosin
No, combat study is a wrong answer. What is the study that supports tamsulosin as a monotherapy?
It's Conroe study, yeah.
Is it? Okay, I don't know about that. That's fine. Okay, anyway. So fine. So what are the classification of alpha blockers?
So there is the non-selective, and there is the selective and the highly selective.
Tell me about the selective. Tell me about the selective.
The selective is like the Zatral, the alpha-zucin, and the highly selective are like the tamsulosin.
Okay, what does highly selective mean?
So highly selective, it means it targeted alpha. alpha 1A receptors.
Okay, very good. How would you assess this patient for surgical intervention?
So this patient, sorry, how old was the patient? I'm sorry.
67.
So 67, and he's having urine retention, and he's having symptoms, severe symptoms, and yeah, we need to have an ultrasound for the patient to assess for the prostate size. We need to also ask about the past medical history and past surgical history, and how is he fit or not. And
he's what? Sorry, say that again. Say that again.
Is he fit for surgery or not?
Okay.
Regarding the comorbidities that he's having, and also the anticoagulation that he's taken, because all these will affect the surgery. Also regarding what's the patient aiming, or what's the patient expectation after the procedure, and if he have some specific needs, like to preserve the sexual function, and to prevent retrograde ejaculation.
Very good. Well done. What about, so the disease factor is the size of the prostate, is that correct? How would you estimate the size of the prostate with an ultrasound?
So with an ultrasound using the Elipizot formula, we have the height, depth, weight, and length by 0.52.
Good. How would you counsel the patient for TRP procedure?
So first of all, I will talk to the patient about what we expect after the procedure. I will say to him that he will be inpatient for 1 night, and in my practice, usually I will talk him the next day, and if there is no hematuria, and if everything is going the right way, I will also talk to him about the complication, including the infection, bleeding, and sepsis, and anesthesia risk, including DVT and PEs, the early long-term complication, including the erectile dysfunction and the retrograde ejaculation and the incontinence, and the late long-term, including the need to have a redo for the TURP, and also failure to improve symptom after the TURP, and the stricture and bladder neck stenosis.
So it's always nice to name some percentages, like enumerate some percentage, especially with erectile dysfunction.
So usually erectile dysfunction, it's between 5 and 10%. The erectile dysfunction, yeah, it's between 2 and 5%, and the incontinence, it's around 1 to 2%, and the redo for the procedure will be 10% in 10 years.
And what about the retrograde ejaculation?
It's 75%, up to 80% can be also.
How do you think you did?
I feel unorganized, to be honest, when I'm answering. That's the thing.
I think you're too humble.
I need to know about the studies, to be honest, from the notes, because I have read the studies from the textbook, which is, I believe, not up to date now. So
no, I think you did very well. MashaAllah, very good. You didn't do any mistakes, really. The study that I'm referring to is Dijavan trial you find in my notes. It's a very important trial. It tells you that if I give tamsulosin within a few days, the flow will improve in 25%. That's a big number, isn't it? Mm-hmm. And the symptoms will improve in 40%, almost half of the patient, just within a few days. Dijavan trial. If you tell me where do we find Dijavan trial in another topic, you'd be an A star. Anyone, guys?
Dijavan trial.
In urology, Dijavan trial. Okay, we'll talk about it later in prostate cancer anyway. So the indication of combination treatment, we didn't ask this question, sorry.
How to combination, yeah, okay, yeah.
Yeah, we didn't. We'll ask it to another candidate. How would you assess the patient for surgical intervention? You did mention it perfectly. You assess the patient's factors and disease factors. You went from the patient expectation, number 1, to comorbidities, to heart problem, anticoagulation, to sexual problems. These are the things you need to mention. And I would also And then you jump to the disease factor, which is the size of the prostate as per the EAU guideline. If it's above 80, 30 to 50, and below 30. And based on these findings, you will determine what's the next step for the patient. We'll see that in the next scenario, obviously. When you counsel the patient, you did very well. I would also mention, as per the BOWS information leaflet, I will discuss the surgical intervention, possible complication, and alternative options. That's really important. And you did counsel the patient very well on the complication. You started by what the patient expects. This is my technique in the exam always, and in my real practice. The patient needs to know what to expect after the procedure. This is what matters for this patient. So you end up with a catheter. You will find yourself on a bed with a catheter, a little bit bloody, with irrigation. It's very likely that we're going to remove your catheter within the next 24 to 48 hours. And also, there is a possibility of experiencing blah, 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 etc. So you did that very well. Good job. Well done.
What's the percentage of the dizziness?
So the dizziness 5 to 9%. And in some textbook, 3 to 5%. In Smith textbook, it's 3 to 5%. In the AUA guideline, it's 5 to 7%. So it's, I would say, 5 to 9% in the safest, to be the safe. The erectile dysfunction, you did mention 3 to 5%. I know where you're reading from. It is also mentioned that it's from 6 to 9%. But anyway, it's all around the same. So it's always important to mention percentage if it's really, if it does matter. If I'm a patient, I'm having this procedure and you're telling me there is a risk of erectile dysfunction up to 10%, that's really concerning from my end, isn't it? From your end, it might be nothing, but from the patient, it's really significant. It's 1 in 10. So I may say, you know what, I don't want this. If you tell me that the retrograde ejaculation is 80%, I may say, no, thank you. So always remember, these percentages are really important, especially with very specific complications like erectile dysfunction, retrograde ejaculation, perforation of the bladder, etc. Okay, who's next?
I can try.
Rakan,
yeah.
Good day. Another question. With TURP, I seem to remember a question some years back. They said if you do a TURP and you inadvertently damage the external sphincter on one side, does that cause incontinence of the patient?
Okay, what's your answer for that?
I would say yes.
It does, yeah, it does.
Okay, okay.
However, it's very interesting you mentioned that. There's an interesting paper called, let me remember that we were discussing this very recently. It's called, do you know, when you start teaching new registrars, like young registrars, TURP, and you keep telling them about the apex of the prostate and be careful of the sphincter, they become overcautious, so they always leave apical part of the prostate, right?
Yeah.
They always do that, always. So when we go with a flexible cystoscopy, if you are a consultant, you know if a consultant did the procedure versus registrar, a junior registrar, because of this apical tissue that's left. There's a paper about this, and they named this apical part, very interesting thing, something like registrar syndrome or something like that, to make fun of this. But this is very interesting because it's not as you think. It's if you the issue is, where is the exact location of the external sphincter? Is it at the proximal part of the vero? Exactly, it's not. So I think, I'm not really sure because you can't see me. But it doesn't go straight from down up 90 degrees. No, it goes like 70 degrees anteriorly. So it's not straight away on the veromontanum. So you have a room to resect all this apical tissue. Anyway, it's not our talk now. Just it's interesting point.
It's a horseshoe shape, you know.
Yeah, tell me.
It's a horseshoe shape, like.
Yeah, exactly, like shoe shape. Yeah, that's true. Yeah. Okay, who's next?
I can try, Rakan.
Okay, who's that? Sorry?
Mohammed.
You did do a case, Mohammed?
No, I didn't.
Oh, sorry.
A lot of Mohammed.
Okay, a lot of Mohammed, yeah. Okay. Yeah. So let's say with the very same case, you were called to the recovery room because the patient feeling dizzy after the TURP procedure. And let's see what's called here. And his catheter is bloody. How would you assess this patient?
So I will assess the patient, make sure the patient is vitally stable. I will go through APC, airway breathing circulation. Then I will examine the patient abdomen to make sure the bladder is not full. Then I will start flushing the catheter for removal of possible clots and make sure that the irrigation is working. And regarding the patient dizziness, I might suspect, I will suspect possible QR syndrome. So I will request some bloods, including APG, urea electrolyte, and
so the
sodium
patient
potassium.
had bipolar. The patient had bipolar TRP.
Okay. So bipolar, as the patient had bipolar TRP, the chance of getting TR syndrome is very rare. The reason for the patient, the possible causes of the patient dizziness might be drop in the hemoglobin level. So I will check the hemoglobin level correctly, and I will take some electrolytes as well for the patient.
Okay, so you started. So the abdomen is palpable. Let's say this is the patient. So the abdomen is palpable. The catheter is very bloody. You tried to irrigate the catheter. It's not really irrigating very well. It's very much clotted. What's your next step?
So that means there is a possibility of clot retention, or the catheter might be blocked by small clots. So I would examine the patient abdomen, and then I might request the ultrasound scan for the abdomen to assess the bladder capacity and possible presence of the clots. And if there is
ultrasound, what you will
bedside
request an
ultrasound.
ultrasound?
Bedside ultrasound.
Do you have that in your hospital? Will you bring an ultrasound bedside into the recovery room? That's unlikely.
So,
frankly speaking.
Okay, fine. Okay, fine. Yeah. So, the first possibility would be clot retention. So I would do bladder washout with bladder syringe to remove the clots and start the irrigation. If this catheter is still not working, I might consider changing the catheter.
Good.
Yeah, I would consider changing the catheter and then try to do bladder washout again and start the irrigation. If it's not working, so the patient will need to take the theater back or check the bladder and check presence of the clots and possible.
Yeah, don't jump the question. So you just wait for the examiner. Good, very good. Okay, so you exchange the catheter. They started to irrigate, but it's very bloody. You try to irrigate more and more and washed out the bladder, and it's still very bloody. Blood is coming. Yeah. There is no more clots. You were able to evacuate the clots. Well done, but it's still very bloody. What would you do?
So I will discuss with the anesthetist. I will take blood group and cross matching for the patient, and consider starting immediately blood transfusion. I will discuss with the anesthetist and the CHR team possible taking the patient back to theater immediately.
Anything else? Where is this bleeding coming from, Mohammed?
It's from the prostate. Yeah. Okay. I got the answer. So I will do filling make sure the balloon is filled with 40 to 50 ml and do traction on the prostate bed. And check the irrigation after a few minutes to check if the bleeding has stopped or not. If it's not stopped, so I will go for the next step.
Okay, very good. So it didn't stop really. Before that, when you inflated the balloon to 50 ml and you put a traction, how would you do the traction?
The traction I will do over the side by using the stat lock over the side. This is one way. The other way, gentle traction by swab over the penis. This is a traditional way. Yeah.
So you did that. It's not stopping. What's your next step?
So the next step will be taking the patient back to theater. If the patient is, taking the patient back to the theater, especially if the patient is not stable and there is severe bleeding, and it easy to go back to theater and the team is available.
What do you expect to find in the theater?
So what I expect to find in the theater for the patient, there is possibility of bleeding coming from the prostate.
Okay, fair enough. What would you do? What would you do?
I will do cystoscopy and diathermy of the prostatic bed after evacuation of the clots.
Where do you expect the bleeding coming from? Like where exactly in the prostate bed?
So prostate bed coming from 5 and 7 o'clock.
What is this plexus called?
Bidunclic. This is.
What is it called again?
I can't remember. Something Bidunclic or something like that. I can't recall it.
Okay.
Sorry for this.
Just the word stuck.
I got why you are laughing. Sorry.
Yeah. Okay. Fine. Okay. Fine. Fair enough. Okay. So the bleeding didn't stop. What's your next step?
If the bleeding didn't stop, so during the theater, so there's two possibilities: either open technique and backing the prostate, or taking stitching in the prostate bed. This is one
How
of the
would you open? How would you open and reach the prostate? Tell me exactly what are the steps.
So open the prostate, I will do either finish-tail incision or exploratory vertical incision, and open the rectus and reach the bladder, and I will swap the peritoneum away, and then I will do open the perivesical fats, or open the bladder and take 2-stage sutures and open it between, and then I will use a deeper retractor to inside the bladder to.
Okay, fine. Yeah, you know the technique. Fine. Okay, we're done. So how do you think you did?
Just some details are missed, actually. Some important details have to be mentioned correctly.
Yes, of course, but overall it's not bad, but there's always room for improvement.
Okay.
But so you struggled a bit in the emergency situation. You could finish this emergency situation in just 1 minute, actually. You don't need to go this far. And you missed important steps. You know that, obviously, because you recapped again. So first of all, whenever I go and see this patient, I will assess the patient's vital signs, airway, breathing, circulation should be assessed straight away. For the examiner, you need to act like a consultant, right, in the exam. So you need to mention to the examiner your differential diagnosis. I'll go and straight away see this patient because most likely I'm expecting either this patient is having possibly hypovolemic issue, hypovolemic shock, or in a very or TR syndrome if he's having monopolar, or in very unlikely scenarios, in less than 3%, he might develop sepsis intraoperatively. So these are the main 3 scenarios, or possibly perforation of the bladder, which is very unlikely, but it's one of the possibilities. Then I need to exclude these one by one. So when you go and see this patient, I will, from up downward, I will assess the vital signs on the wall. Then I look at the face of the patient, talk with him briefly, making sure that he's conscious and oriented. If he's experiencing any pain, then I continue going down, assessing the bladder of the patient. Is it full or not? Then I continue going down, assessing the catheter of the patient. Okay, let me just, guys, check my face because you need to see me properly. Okay. Let me stop sharing for a second. Guys, do you see my slides?
No, now no.
What's happening? Okay, fine. I don't know what's happening really here. Okay, fine, I got it. Okay, can you see my slides?
Yes.
Right. So the easiest way to deal with emergency case, go from up downward. So assess the vitals, assess the facial expression, and talk to the patient to make sure he's oriented and conscious. Then you go down to the abdomen, then you get down to the catheter. So you went to the abdomen, you see a palpable bladder. So I almost made the diagnosis. It's either clot retention or possibly perforation of the bladder. It could be, isn't it? It could be perforation of the bladder, and the fluid is filling the abdomen. So I will deal with the catheter. Always remember that. Let me show you something very interesting I use in my exam always when I did the exam. So whenever you deal with an emergency case, this is the central point. This is the patient. This is me. And on my side, always there's an SHO. On the other side, always a nurse. This is what I use. This is my orientation in the exam. So whenever I talk, I move this team all with me. So always I'll go and see this patient. I'll ask the SHO to follow me, and I'll talk to the nurse. I request a blood from the nurse, and I'll ask the SHO to prepare the bag for me, or to prepare a new catheter for me. Always involve the team with you. This is what the examiner expects from you as a consultant. You never go and do this case alone. There should be a nurse, there should be an F1 helping you. The F1 will take the blood, the nurse will do the ABG or whatsoever. So go as a team. Always, 3 of you go together. In the emergency situation, kidney trauma, all together, the SHO on my right and the nurse on my left. Always think this way, orientation-wise. Obviously, when you emptied the clots, the patient is still bleeding, so I'm expecting that he's bleeding from the prostatic fossa. So you deflate the catheter, inflate with 50, and just proper traction. What is the chance the bleeding stops with proper traction? 70%. AUA guideline. 70% will stop, so there's a good chance. How would you do the traction? The same way you mentioned, or I will do the traction myself. And this is what we do in real practice. You will keep track 10 minutes, proper traction yourself, because you're very much scared of taking the patient back to the theater. You don't want this to happen. So I do the proper traction myself, keep pulling the catheter. And this is what I do after any TURP. Generally, I just do a little bit of traction intraoperatively until the urine is clear. Then I release it, obviously. Or you put a gauze, as you all do probably. When you take the patient in, obviously you need to mention that what's the function of the nurse and what's the function of the SHO. The function of the nurse: request cross-matching, prepare blood, etc. And you didn't mention consenting the patient for going back or talk to his next of kin. You need to mention all that. That's why you come from the exam thinking you did very well and probably you failed the exam. Very simple stuff make a big difference. Very simple stuff brings you from 6 to 8. Okay. And when you open the patient, it's by the way, it's badenoch plexus. When you open the patient, don't go into detail. I don't want to know what dever, the dever you want to put in the bladder. That's overkilling. That will waste your time. Just go with simple steps. So I'll go extraperitoneal. I will open the abdominal wall, including the bladder. After peeling off the peritone, I will just suture the bleeding site, most likely at 7 and 5 o'clock position. If it's not working, I may pack I may use Surgicel, or I may pack the bladder with gauzes and bring him the next day under GA to remove it. As simple as that. Okay. Who's next? Who's next, guys?
I can do the next one.
Is it Ayman?
No, Arabiat.
Arabiat.
So
okay.
yeah, I just came from CBOT case, so just joining you now. So.
Okay. Let me put a timer. Okay, go ahead.
Question, Sorry.
Tell me.
Yeah, just about the patient. He said if you are the patient is going back to the theater. He said after his consent. So there's a verbal consent, isn't it? It's not like a written consent.
Well, if he can sign, it's better. If he's conscious, he can sign. I wouldn't. If he can sign, I will make him sign. Really, this is what we do. We did take many patients back to the theater. I wouldn't go and open the patient's abdomen, really, on just because it's not. If the patient is conscious, because you need a consent. You can't take him verbally. Either consent 4, where you where you take over and you consent for the patient if he's not conscious, for example. Or you can use even the next of kin cannot consent. It can be supportive as a consenter with consent 4, but I wouldn't take the patient back to the theater without a consent, just verbal consent. I wouldn't do that. No.
Okay, thank you.
You can use consent 4 if he's not conscious, obviously.
Yep, thanks.
And you need, guys, by the way, just speaking of consent, you need to know what's consent 1, 2, 3, 4. You know that, right?
Yeah, of course.
Okay, fine. We'll talk about this in technology anyway.
Sorry,
okay.
just a question.
Yeah.
Okay. So who's next?
Yeah.
I can. Sorry, just I want a question if you don't mind.
Yeah, go ahead.
So we need to consent to say I will consent him for cystoscopy plus diathermy plus minus open cystostomy. Am I right?
Yes, you're right.
Okay, thank you.
Good job. Okay.
So just a quick one, Rakan.
Yeah.
Is in such situation, is it a good point to say we'll look for support from like one of my colleagues, or it's a bad point in this situation? If you ask for help?
Is it Ayman who's asking?
Yes, yeah.
Well, it's either deja vu or you asked this question long time ago. Am I correct?
I'm not sure.
Well,
it's always
you
in
did
my
ask. You did ask this question long time ago. I just it's kind
this,
of like
in this situation.
Yeah,
because I always think about such things in difficult situations. Is it good to ask for support or not?
So, okay, that's a very important question. So if it is a very, like, for example, if you're going to open a renal trauma and you are a first day consultant or you're an endourologist, yeah, I would consider that. Or you're doing reimplantation of the ureter, you need one of the uro-oncologist. But for a bladder injury and just opening the bladder, I don't think it's relevant to say I will ask someone to help.
Yeah. Okay.
Because the next question, even if you need help, I'm not saying any one of us could need help, right, for anything. But I think he will tell you, probably he will say, haven't you ever opened a bladder, like did an emergency bladder surgery? So I wouldn't say that in this scenario. Probably in renal trauma, it makes sense. Reimplantation, emergency reimplantation, that makes sense.
Yeah.
If you are going even transperitoneal, really, it should be fine if you are repairing the bladder only. But anything ureteric, obviously you need definitely need help.
Thank you.
Okay, dokie. Who's next?
Yeah, it's me, Arabiat.
Okay, Arabiat, go ahead.
Okay. Okay, 59-year-old gentleman presented to you with lower urinary tract symptoms, microscopic hematuria. Examination showed no abnormalities. What investigations would you request? So propose that I've taken full history and examination. The investigations that I would do, normally we, before seeing any patients regarding the lower urinary tract symptoms, we have a pre-filled bladder diary along with IPSS score. And because he has microscopic hematuria, we'll need to arrange for an ultrasound along with a flexible cystoscopy. And also we will arrange to have a urine depth and along with a urine culture if appropriate, and also UNEs, EGFR, and complete blood count. And I will counsel him regarding PSA.
So what are the indication of PSA as per NICE guidelines?
As per NICE guidelines, I would request a PSA for any patient who presented with lower urinary tract symptoms, a patient who had an abnormal DRE, a patient who has hematuria, and sometimes patients after the age of 50 as a part of the screening, according to patient preference.
The patient had a flow rate showing Qmax is 9 milliliter per second. His voided volume is 101 milliliter. What's your next step?
So my next step, because depending on this flow rate, it's insufficient to judge on this flow rate, as the voided volume is 101. And so normally with the lower urinary tract symptoms and with this, according to the NICE guidelines, this is an indication to do urodynamics.
So take me through it.
Yeah. So this is urodynamics trace. there is what I can't. I think it's adequate subtractions. What I can see there is, which I believe there is detrusor overactivity, which also there is incontinence with it. Yeah, it's very small. It's just on the phone, but yeah.
Okay,
because I think the blue is the P vesicle. So yeah, I think there is detrusor overactivity along with incontinence, which I think there's
probably, you know what, yeah, you are correct, obviously, but it seems like this is the wrong urodynamic. Okay, fine, but there is a detrusor overactivity with leakage. I agree with you. Okay, so let's assume that this is obstructive voiding phase and it shows obstructive pattern. How would you assess the obstruction and the urodynamics?
So on the urodynamics, we use the Abraham Griffin's chart. We normally it's the we have a chart that with the which is the what we call it bladder outlet obstruction index, which is 2 Qmax. Detrusor muscle detrusor pressure at Qmax minus 2 Qmax, which is we have 3 areas. Which, if it's more than 40, it would be considered as obstructive. Between 20 and 40, it's equivocal. Less than 20, it's not obstructive.
Well done. The patient decided to proceed. So there's an obstructive pattern, and he's not responding to tamsulosin. The patient decided to proceed with intervention. You did assess the patient as per patient's factor and disease factors. How would you consent the patient for a HOLIP procedure provided that his process is 120 cc?
Okay, so yeah, I would first of all, I will use the BAUS information leaflet by consenting the patient. I'll need to mention him the alternatives, outcomes, also the recovery and the what he expects and the possible complications. So normally the HOLIP procedure, it's a laser operation. Normally in our trust, we admit the patients and we normally keep a catheter afterwards and we send them home. We talk them the next day and send them home after. So the HOLIP, it's the possible complications for this is almost in all the patients, they may have retrograde ejaculation, also the risk of bleeding, which is slightly lower than the TURP, not slightly lower than the TURP, also the injury to the bladder itself, the bleeding, the need for transfusion, and also the anesthetics risks like having PE, blood clots in the heart problems, DVT, chest infections, and also I will consider mentioning the possible risks for reoperation, which is almost 0.8%, and also the that's
okay, fine. So any study support what you said?
So the study, I think it's Gelling study, which shows that HOLIP is not. It has this same efficiency as TURP, but with less complications.
What is the energy of HOLIP? What's the wavelength of HOLIP first?
So the wavelength, it's 2041 to 2041, and the normal energy. So the energy is, I think the power is 100 joules, and the frequency is 40 to 50 hertz, and the the power is 100, energy is 2 joules, and the frequency is 40 to 50 hertz.
Okay. You have a 74-year-old gentleman presented to any department with urinary retention. How would you assess this patient?
So I will need to see this patient urgently in the A&E. I'll need to check that the patient is stable. I'll need to make sure that has he had any catheter or not. I'll need to take a brief history, see if he has any comorbidities, if he had any previous diagnosis of prostate, BPH, or any prostate cancer, if he had any previous operations, especially pelvic operations, and has he had this before. Also, I will need to ask the nurses to prepare a catheter, of course, if there's any SHO, to try to put a catheter, see how difficult it is. If we manage to put the catheter, we'll need to document urine outputs, and also to, during that, we'll ask the nurse to take some bloods to check UNE's kidney function, and also
okay,
I'll
we're done.
All right.
Well done. So, Arabiata, did you do the exam before?
Yeah, I've done it.
You did very well. MashaAllah. Very good.
Thank you.
It just probably it wasn't your day, I think.
Yeah, it was a close more than 3 marks, but yeah, that's fine.
Yeah, you did very well. Very good speed. Very clear. Very much organized. Everything you said is almost correct. So let's start from where we ended. Very good that you picked the microscopic hematuria with LUTS at the age of 59. However, that's not a 2-week wait. You need to know that, right? It's not 2-week wait, not 2-week wait. Because it should be above the age of 60 if it's, and with dysuria or leukocytosis, not pyuria, like I used to say before, leukocytosis. So very good, you picked that, and then you went through the investigation very well. You always remember, patient with LUTS, the only thing I would do differently is I always mention, and this is all in my notes, whenever patients presented with LUTS, the patient comes with BUP, bladder diary, urine dip, post-voiding, and flow rate, and IPS score. You mentioned that in different time during your answer, but I would start always with that. Even in the female urology, she comes with bladder diary, urine dip, post-voiding, and incontinence questionnaire, BUP, the same thing. Even in kids, bladder diary, urine dip, post-voiding, and ultrasound, BUP. So that will make things easier, and it will show the examiner that you are very well organized. And you went through the case very smoothly, very well done. The indication of PSA correctly mentioned. Qmax, always remember, Arabiata, you need to boost your mark somehow. Because in this exam, it's very easy to pass and very easy to fail. You know that, right? Yeah. You might think you did very well, and at the end you get a poor mark. The only way to prevent that from happening, apart from having zero, 100% knowledge, no gap, is by providing more and more supportive evidence. If you do that, it's very unlikely for you to fail, provided that it might boost your mark. So flow rate, for example, just mention Renard trial. So I know, even if it's inaccurate, I know that as per the Renard trial, it looks like an obstructed system. However, because it's like whenever I have a chance to drop a study, I just drop a study. Yeah. For example, this is a wrong urodynamic. I apologize for that. All right. Like, for example, there's one like HOLIP procedure. I don't need to prompt you for HOLIP. Obviously, when you mention laser, you definitely need to present a study. Definitely, there's no doubt. So you can mention Almansi trial. You can mention even the famous trial of the TRP. What is it called?
Cornu meta-analysis.
Cornu meta-analysis. It did compare between HOLIP and TRP, and you did mention the comparison actually in regard to bleeding and hospital stay, etc. So why didn't I mention HOLIP? That will boost your mark. And very good about the laser. Very well done. Good job, really.
Thank you.
Very good job. Okay, who's next? Anyone? Guys, who's doing the exam in November?
I'm happy to try again if no one is taking it.
Me too, yeah.
Mustafa, go ahead.
Yeah.
You have a 74-year-old gentleman presented with retention. How would you assess this patient? Let's start from there.
So I'll immediately go on to this patient myself in E&E. First of all, I'll make sure the patient is catheterized and the urine output is documented. After that, I would take a proper history from the patient, asking about any onset course duration of his symptoms, any associated symptoms, and any other.
I can't hear you very well, sorry.
Signs. Then I'll ask about his past medical history, his past urological history, and his drug history as well. Following that, in the presence of chaperone, I would like to examine the patient, starting by general examination and then abdominal examination, genitalia examination, and DRE. I would also perform a neurological examination.
There is some.
And following that, I will arrange for the patient to have investigations. Sorry?
There is something wrong with your connection, or it's only me? I can't hear you like properly?
Yeah,
Is it only me?
No, I think it's the connection
Yeah,
from
Dwara,
Okay, fine. Okay, continue. Okay, fine. Fine. Okay. Always don't jump to the next question answer. So history shows back pain. There is mild lower limb numbness. I'm not sure. I couldn't hear you if you mentioned examination of the lower limb. Probably you did.
I did mention. Yeah.
Very good. And there is loin pain. DRE is nodular. And there is a loss of sensation or changing in the sensation of his lower limb. What's your next step? Tell me, what are you going to tell the examiner?
So with these examination findings, I'm concerned about this patient having a metastatic spinal cord compression, probably due to prostate cancer. I would like to arrange for an urgent MRI spine for this patient, and also I will inform I'll get a PSA and inform. I'll get a PSA and make sure patient is nursing in bed rest in a flat position with complete bed rest.
Okay, you did the MRI scan. You did call the MRI scan, or you asked your junior to book you the MRI scan. He did book it. It's going to happen on next Friday. What's your next step?
Next Friday, I understand that in suspicions of with suspicion of metastatic spinal cord compression, MRI scan has to happen within 24 hours. So I would call the radiology consultant myself, explain the situation, and try to move this scan forward to happen within the next 24 hours. With the high suspicions of the metastatic spinal cord compression, I would also start this patient on dexamethasone 60 milligrams, and then I would inform the metastatic spinal cord compression coordinator, and also inform the acute oncology team. I did mention the PSA. Yeah.
Okay, fine, good. So the PSA is 140. What's your next step here?
After the MRI scan, or
before MRI scan, even are you considering anything?
This is likely a metastatic prostate cancer, so I would counsel the patient for Digaralex with a stat dose of 240 milligrams, 120 each, and then following that 80 milligrams monthly.
Very good. What is the mechanism of Digaralex?
So Digaralex is a gonadotropin-releasing hormone agonist, which will cause castration.
Is it?
Sorry, antagonist. Sorry. Antagonist. Sorry, which will cause castration, which will cause castrate level at around 3 days.
Okay, it's 48 hours. Fine. Okay, very well. So this is the MRI scan. Take me through it and tell me what's your next step.
So this is a sagittal image of an MRI scan, which showing disc herniation at the level of I think this is L4. Provided that the patient is started on the dexamethasone and Digaralex, and the metastatic spinal cord coordinator and acute oncology team have been involved in this patient care, I would provide instructions for the nursing staff for this patient to be at complete bed rest, and also arrange for him to have a pony scan and CT chest, abdomen, pelvis, provided his EGFR is normal, and discuss his case in the urology MDT.
Fine. So why do you want to involve the oncology team?
Actually, this is the protocol in our trust, is to involve the metastatic spinal cord coordinator.
That's not the answer. So why is it a protocol? Why do you need to involve the oncology team? Why in a spinal cord compression we have to involve the oncology team? Any other teams you need to involve?
Neurosurgery.
Neurosurgery.
Why do you want to involve the neurosurgeons?
For decompression.
In case if this patient requires surgical decompression.